Good afternoon, everybody. Great to see all of you. And I know there's not a big crowd at the moment, but I also know people kind of end up joining later and later as time goes on. And I do have a favorite story which I like to share. And that is I one day went for a talk at an international conference. And I ended up and there were only 3 people in the audience. And the organizers told me, let's cancel it. And I said, no, I've prepared, they've come, we're going to do it. Those 3 people have become the most amazing advocates for rare disease and is still part of our project to today. So numbers doesn't matter, content matters. And for that matter, I've got some real world experts for you today. For those of you which are new, Aimee brings us the more pediatric kind of background. We've got the novelty in the UK. We actually have both adult and pediatric divisions for our rare disease patients, and Derralynn more the adult part of it. And we are definitely going to have a poll at the end just to get some more information for the next one, because as you know, this is one of a series of 4, and it's a kind of a slow build up all the time. But it's that repetition is really, really important. And of course, it will be recorded and also it will be available afterwards as well. And we always encourage people to put some questions in the chat while we're going on, and then we'll take them all towards the end. So really, and there will also be some valuable materials and things. So lots to look forward to. So I'm going to hand it over to those sharing, and I will just go off screen and audio because I've picked up this horrible things which everybody calls Frankenstein, where I keep on coughing and bumping my head around, which will be very distracting, but I am here. So welcome to all, and I'm going to hand it over to Derralynn and Aimee.
Wonderful. Thank you so much, Chris. It's really lovely to be here and to be seeing some of you again who came along a few weeks ago. So we're going to today continue that discussion on neuronopathic Gaucher disease. Last time we thought about diagnosis and how we might have alert symptoms which might suggest a diagnosis of neuronopathic Gaucher disease. And today we're going to think a bit more about long-term complications and then management. And particularly management where we might not have much in the way of resources. So as previously, that will be a joint presentation between Aimee and myself, and I'm going to share the slides and then hand over to Aimee, and I'll move them along, and then I'll come in a little while. So I will first of all share this, and then I will make this happen, and hugely you should be able to see the first slide.
Yeah, absolutely. So as Professor Hughes says, we're going to think about management of neuronopathic Gaucher disease and the kind of journey over time, so the kind of longer term journey of our patients with NGD. And we're going to focus on sort of long-term complications, the practicalities of managing these patients when you might have limited access to resources. And then we're going to talk about building a sustainable care framework in an African healthcare setting. So this really is designed to be practical kind of tips and ideas and thoughts, helping you to think about this cohort of patients whose needs change over time, and where you may not have, you know, when you look at the literature and we talk about what we might do in the UK or in the US, which might not be appropriate or available to you. So let's go to the first slide.
All right. Not moving for some reason.
Not yet.
No. There we go. That's
just a bit slow.
Yeah.
So we first have to remember that neuronopathic Gaucher, or GD3, is a progressive life-limiting condition. So this isn't a condition that we have any, we don't have control over that progression, but we can do things to make that journey for patients better. And enzyme replacement therapy, we talked about it last time, it does help systemic manifestations of disease. So it helps bone disease, it helps blood counts to normalize. but it doesn't cross the blood-brain barrier, and so it can't stop or change that neurological decline. The caveat to that being that I always say to people, and I'm sure I said this last time, that I think the better your systemic health, the better your brain health. But that doesn't change that pathological process of neurodegeneration, which is happening at variable rates between different patients in the context of GD3. So even in our setting, we struggle with some of these challenges. So we're going to look at what these challenges are. So the long-term kind of complications or the journey of patients. So I've put this graph here, and it kind of doesn't really matter, but the point of this graph is to show you, so we've got a group of these little orange triangles, and we've got a group of the little blue squares and then the green squares. And this is 3 different disease severities of type 3 Gaucher disease. And what you can see is that the time at which different events occur is slightly different depending on the disease severity. And this is just to point out that there is a spectrum in GD3 of different disease severity, but all patients will have an eye movement difficulty. So that's saccadic eye movement defect that we talked about at the beginning. And in those severely affected patients, there's also some bulbar disease early on in the condition. Patients then typically, at whatever rate, depending on their disease severity, will develop some differences in their tone and movement. They may go on to develop seizures at a slightly later stage, and then slightly later again, they develop more signs of the cerebellar involvement of Gaucher disease, so ataxias, tremors, other movement disorders. And also, I think it's really important, something that we often overlook in Gaucher disease is that we know that some of the pathology with Gaucher disease that affects the brain is in the cerebellum. And it's really critical in neurodevelopment and particularly in social communication. So we often see children and young people with quite severe GD3 with autistic features or difficulties in their social communication. And that is probably disease related as well. Go to the next one. So thinking about what that neurological progression looks like, we do see gradual deterioration in oculomotor function. So that saccadic eye movement function that we talked about last time will progressively worsen. So it starts off as a difficulty initiating saccadic eye movements become slow, and over time they're lost. And that's typically horizontal first and then vertical. And while it's often not felt to be that clinically significant, it doesn't change your life completely having this eye movement difficulty. It is important for children and young people when they're trying to learn. And so simple things that we can do is alter size of text, sit them in a different part of the classroom. So supporting education and learning just by observing that this is something that they may find difficult is really important and can have a big impact. We then have to think about epilepsy and seizure management, which we've kind of highlighted at the start there. We see seizures develop in some patients, so the more severe the disease is, the earlier that seizure onset will be. Not all patients develop seizures and epilepsy, but many will do. And often, because this is a neurodegenerative disease process, and so there's a continued kind of hit to the brain over time, this seizure control can get worse over time despite medications. And we have to help families to understand that this is part of disease progression rather than any failure of any treatment or intervention that you've offered. We do see with a certain type of GD3, we see particularly what we call a myoclonic epilepsy, which is really difficult to manage. So these are jerking epilepsies, which has a big impact on mobility, fine motor function, speech, swallowing. We see across most patients, if you were to do an EEG, we would see background slowing on the EEG. What I personally tend to advocate is that we treat our patients and not their EEG. And so I'm not insistent that all patients have EEGs, but where there's an uncertainty about whether there's seizure activity or we want to understand that seizure activity better, EEG can be helpful. But we see all the different types of seizures in GD3. And so some of your patients may have one seizure type, another patient might have another seizure type. And some patients will have multiple different types of seizures at different time points. And they do often, unfortunately, become refractory to standard anticonvulsant medicines. And when we talk about refractory, we're really meaning that they've not responded to two medicines in a row. And so, and as we say with all epilepsies, the more medicines that you've tried and not successfully managed the seizures with, the less likely it is that you're going to gain seizure control over time. We also think about movement disorders, and they can be in lots of different forms, but they affect quite a significant portion of our patients. So the cerebellar ataxia is probably the kind of easiest to recognize, and which might be something that you read about quite commonly. In the cohort of patients that I've looked after, that tends to be quite a late feature of disease, but in other groups, it happens earlier. And the ataxia can manifest in difficulties with walking, but it can also be tremors and dysmetria and difficulty with fine motor function as a result of the cerebellar disease. Spasticity and dystonia are other problems that patients report, and sometimes it's under-recognized. They might report pain, they might report cramps, and actually what you find when you examine patients is that they have increased tone, and they get periods of dystonia, which is actually potentially manageable. We also have seen reports in the literature, and I've seen it in some of my patients, some kind of hyperkinetic movements, particularly around the face and around the mouth, which aren't always intrusive, but they can be quite intrusive for patients who find them distressing. And so we have to think about whether something is functionally impairing and stopping a patient from doing something that they would like to be able to do. For example, the ataxia or the myoclonus stopping walking, but also the impact on that patient's independence, self-confidence, and ability to confidently function within their social network. And so what we can sometimes see is that a patient that you think has been doing really quite well in childhood, that later into adolescence and early adulthood may start to need more supports as their disease changes over time. And that change, it's not a sudden change, it's a gradual change that you see. You have to kind of get to know your patients really well to be able to recognize that these changes and help to prepare them for changes that might come. Next slide. So the cognitive changes, so we're thinking here about intellectual functioning, social functioning for patients, is really quite variable. And what you'll see when you look at the kind of literature on the cognitive impact of type 3 Gaucher is that actually many patients, they don't regress in the same way that we would see in some of the other lysosomal disorders, which have a significant kind of dementia aspect to them. But we do see it in some. And I think that's really important that we recognize that while it's not necessarily a common feature of some cohorts of patients, for some patients, they really do lose skills and abilities to interact. So you may see some young people with mild intellectual difficulty, but functioning quite well. But you may see others who have done okay. And then at periods of what I think of kind of intellectual stress. So I often see it at transition from primary school to secondary school settings, or from the end of secondary school setting into early adulthood. There's a kind of the burden on the brain at those points in times seems to be so significant that we start to see those patients that the difficulties are really become quite clear. So those might be difficulties in interacting, difficulties with memory, intellectual difficulties that weren't previously recognizable. And what is interesting with many of our patients, particularly those kind of with an intermediate form, is that they have quite good verbal skills. And I think many of them are able to mask some of their difficulties with their verbal skills. And so without really digging into what they understand and what they're able to do, you could miss an intellectual difficulty that really is there. Bulbar dysfunction is something that we typically think of when we think of our severely affected type 2 Gaucher patients, so our infants with a really severe form of neuronopathic disease. But we do see this in some of our older patients as well with a more intermediate course, and they can have difficulty with swallowing over time. They can have sleep apnea, respiratory complications, and obviously cranial nerve palsies. And we talked about that as a bit of a clue that I would always take on board, that if I saw a squint in a young child early on, I would be concerned that they had a more severe form of GD3. So if you're starting to see difficulties with swallowing, taking a long time to eat food the way that you would in any other neurodevelopmental condition, that should be a little warning flag that this patient is struggling, and they're at risk of some serious complications, and really interventions need to be put in place for these patients. And then we need to think as well that this patient with GD3 doesn't just have the neurological complications, they also have all of the systemic complications of Gaucher disease. And I think we mentioned it last time, but I often tend to think of type 3 Gaucher disease as being this more invasive, more florid form of Gaucher disease. It just seems to get in everywhere and cause more problems. And certainly in some other parts of Africa and other parts around the world, some of the cohorts have really quite challenging systemic disease complications. And so these would include skeletal disease, so more bone pain. And interestingly, when we asked our own GD3 cohort about what bothers them most, many of them told us it's bone pain. And many of us, we're thinking about the neurology all the time and thinking, oh, it must be X, Y, and Z as a problem, but actually bone pain and fatigue are really significant for our patients. And so we shouldn't be distracted by the neuronopathic label that we give to these patients and remember that they have invasive Gaucher disease. So we need to think about the bones, and we need to think about their hematology, so their bleeding risk, their anemia, their persistent thrombocytopenia. And of course, as a pediatrician, I'm always going to talk to you about growth and development, because everything that's happening in your body as a child comes back to your growth and your nutritional status. So we see growth delays in this cohort of patients. We sometimes see delayed puberty and failure to thrive or growth faltering despite good nutrition. And so all of this shouldn't be forgotten in the context of GD3. We've just added in kyphosis and scoliosis because, again, this is something that we see predominantly in our GD3 population. Of course, we can see kyphosis in patients with GD1 who have vertebral disease, so they've got bone disease in their vertebra. But we see kyphosis and scoliosis evolve in children with GD3. And they have no vertebral bone disease. And this can be really quite marked in the most severely affected, and tends to get worse during periods of growth. So if you think about the stress on the spine, where tone is impaired, we tend to see that manifest, particularly in adolescence. I'd really recommend that we use whole spine erect plane films. So it's not necessary, although my spinal surgeon here might tell me that I need to have an MRI of the spine. Actually, an erect upright will give you a really good idea about the curvature of the spine, and that helps you with monitoring. I always encourage patients, particularly in childhood, to maintain mobility and movement. If you've got access to physiotherapy, I think that's a good practice to start early on. We have used bracing for kyphosis in children, but most of my children will not tolerate a brace, and they're uncomfortable and they're not practical, and I'm not entirely convinced as to how effective they are. But we do need to address pain management and probably just as importantly, the psychological support, because this is the one aspect of disease that the patients will tell me, I really don't like the fact that my back looks different, or the other children that they're around will comment on why is your back the shape it is, and they get quite self-conscious, and that's something that we can support them with. There's not a treatment specifically, but it's something that we can offer support to. We have done spinal surgery for patients with severe kyphosis and scoliosis, but I'm very cautious about making that as a recommendation. There can be some really significant complications. It is really major surgery, and you really do need specialist expertise. There's very few spinal surgeons that will operate Gaucher patients, and I wouldn't recommend it where you've got significant bone disease. So it's not something that I would say is a routine recommendation, but it's something to be aware of in case you have a family who's asking you about it. I think you need to be equipped to have those conversations. And then psychosocial complications, we've kind of touched on them throughout each of those different pieces. But we have to think that our patients are living with a rare condition with not a huge amount of information available, with physical difficulties which impair their ability to interact, and possibly intellectual or social communication difficulties which have an impact on their ability to function independently. And all of this can really have a big impact on both their integration into their community, their employment or their learning, and the relationships that are around them, both with friends but also with their caregivers. And for family members, there is a big burden of worry, concern, that grief of witnessing somebody deteriorate that you're there to protect and care for, when there's a lot of uncertainty. So I think there's a big psychosocial implication of a diagnosis of GD3, both for the patient and for the caregivers around them. And we certainly see quite a significant burden of depression and anxiety, particularly in our young adults with GD3 in our community. And I would expect that that is shared across the globe.
Okay, so I think I take over at this point. So having thought about some of the longer term complications and progression of neuronopathic Gaucher, we thought it would be helpful maybe to think a little bit about treatment, and particularly the supportive treatment when we may not, first of all, have an optimal treatment which crosses through into the brain, or when enzyme therapy itself might be limited. And as Aimee said, we would really very much support using Gaucher specific treatments, enzyme treatments in patients with GD3 to optimize this systemic manifestations. But I'd like also to say that symptomatic management can in itself be really important, especially if you can't use enzyme very quickly, if you have to wait for approvals or wait for compassionate access schemes. So we have potentially life-threatening complications with thrombocytopenia. And so from a hematology point of view, we'd suggest monitoring the platelet count, and when it's really low, monitoring it fairly frequently if that's possible, avoiding antiplatelet agents such as aspirin and non-steroidals, and thinking about prophylactic platelet transfusions before any procedures. So, for example, if you are going to consider orthopedic surgery for a patient, really thinking about both the number and also the function of the platelets to avoid bleeding. And that might be something which is particularly important for adolescent girls starting periods, or before women give birth, thinking about what the potential bleeding complications might be for them. On the side of anemia, mostly, of course, this will not be due to iron deficiency or other hematinics. But if people are bleeding because of a thrombocytopenia or platelet dysfunction, then it may be that you will get some response from iron supplementation, or even folic acid if there's a high turnover. So I think both important, very simple and cost-effective considerations in any healthcare setting. I'd also suggest treating infections and any chronic inflammation properly, because that will also make the anemia worse. And then thinking about transfusions if people are really very symptomatic from anemia point of view, bearing in mind, of course, that there's potential for transfusion-related complications. So basic blood tests, iron, B12, folate, all pretty achievable and hopefully relatively straightforward. The next aspect of supportive care would be pain management. And we know that patients may experience acute bone crises. And this is terribly debilitating for patients. It often is not much defined other than an area of acute pain. It looks like inflammation, may even look like a bone infection, but with a sterile blood culture. And patients sometimes require hospitalization for severe episodes of bone pain and bone crisis, not dissimilar to a sickle cell crisis requiring hydration, parenteral opioids, rest, and immobilization. Important also to exclude concomitant infections or pathological fractures. And important to treat that so that it doesn't become something which is really very both physically and psychologically debilitating for patients. There may be a background of chronic bone pain, and just thinking through the analgesic ladder here is helpful with paracetamol, potentially weaker or stronger opioids if they're available. But neuropathic pain agents such as amitriptyline and gabapentin might also be effective in these situations, and so can be helpful, even though you may not anticipate they would be because of the nature of the pain. If you have availability of physical therapy or of gentle exercise, that can be helpful in maintaining mobility. And when people are very unwell as time goes on, potentially with neuronopathic Gaucher, also thinking about exercising, about reducing contractures, for example, if people are confined to a particular position, and then psychological support and coping strategies for that. Aimee mentioned that there may over time become problems with tone due to the neurological complications, particularly in children with severe disease. There could be increased muscle tone in the arms and legs, and this can be challenging. And so again, simple medications, including baclofen or diazepam, may be helpful, and again, gabapentin. Or other considerations of supportive care, so physiotherapy and pain relief. How can we teach the family to administer this so that it's supportive within a normal family social environment, and helping patients and families to be able to assess and deal with the impacts of increased tone, so sitting, washing, activities of daily living. And I would suggest that one thing which is important is the possibility of pathological fractures. And we see this in our patients, that because of increased tone, there's potential for dislocation, and for very simple and small abnormal movements resulting in a fall and a fracture, which can be devastating if healing is delayed. Seizures can become progressively more difficult to manage. Aimee has already touched on this. We're a little hesitant to suggest particular treatments for seizures, and we should refer you really to your local guidelines for seizure management, your local neurological experts, and also if you're looking on the UK guidelines, then on the NICE, the National Institute for Clinical Excellence guidelines. I'm working through usual treatments, including valproate, levetiracetam, and then thinking specifically in terms of myoclonic seizures, how you might deal with breakthrough myoclonus, for example, with clonazepam, and avoiding medications that might make myoclonus work, such as phenytoin and carbamazepine. It may not be realistic to completely achieve a seizure-free life. So it's important with patients and with their families to risk assess that, to manage it as safely and as acceptably, as satisfactorily as possible, enabling the family perhaps to have rescue medications and be able to keep the patient safe. So along with treating supportively, we'd suggest trying to prevent complications. So how do we protect the skeleton? Enzyme treatment may be very helpful for that, but also optimizing calcium, vitamin D if that's possible. We're using weight-bearing exercises if you can tolerate that, preventing falls, thinking about physiotherapy early on, and avoiding high-impact activities to prevent fractures. But if they do occur, ensuring that there is an action plan, that they can be treated promptly and appropriately. I'd suggest also thinking about infection prevention. Patients may have had a splenectomy. We talked in the last webinar about ideally avoiding splenectomy until after a diagnosis, or avoiding it altogether, but it does sometimes occur. So in the case of splenectomy, obviously using prophylactic antibiotics and vaccinations if that's possible, but again, prompt treatment of those infections, considering the impact of somebody who is asplenic on infections, and good dental hygiene. And as patients progress and may develop bulbar problems, we should think about swallowing assessments, about textured diet, so that we can try to prevent an aspiration. If that does occur, thinking about the organisms for aspiration, appropriate treatment and physiotherapy. And in some cases, as risk of aspiration, or if feeding becomes more difficult, considering a PEG tube before severe malnutrition develops, which may impact on wound healing. Other aspects of supportive care would include nutritional support, so high calorie, nutrition dense foods if that's possible, small and frequent meals, supplements and addressing those feeding difficulties. Physiotherapy and rehab, I think we've mentioned quite a few times, but strengthening, thinking about gait, mobility aids, chest physiotherapy and occupational therapy. And educational support, considering particularly hearing and autism, and in a schooling situation, extra time for examinations, consideration of seating arrangements for vision and hearing, and communicating with families and with teachers about the potential problems that young people with neuronopathic Gaucher disease might have. And for all our patients, in whatever healthcare setting, I can't overestimate the importance of psychological support, counselling, enabling people to move through the different stages of the condition, screening for and treatment of depression, and family therapy where there's a caregiver burden, potentially with more than one sibling with neuronopathic Gaucher disease in the same family, and adjustments as patients come to end stage disease, end of life, and requirement for palliative care. We should consider when to refer patients, so that we thinking about optimizing platelet count, anemia, infection before surgical considerations. We mentioned orthopedic surgery. Those are the things which may occur for our patients. We generally try to avoid splenectomy, but if there is massive splenomegaly, which is unresponsive to other interventions, and which leads to severe cytopenias, respiratory compromise, infarctions, thrombocytopenia, which are themselves life-threatening, then splenectomy may be an appropriate intervention, but would require a very experienced surgical centre, consideration of platelets, clotting beforehand, and then lifelong treatment with antibiotics. If transient loss of swallowing or neurology occurs around those surgical procedures, which we've seen, then careful post-op follow-up. Recognition that this isn't necessarily, in this particular instance, disease progression. It may be something transient associated with the surgery, but would require intervention to avoid aspiration. So finally, just a few thoughts as to how, again, in any healthcare setting, we can set up services so that we can give maybe the most appropriate services locally. So in a district hospital, thinking as we did last time around clinical diagnosis and around basic monitoring, blood counts, hemotonics, management of seizures and pain, vaccination. It may be that we need help from more specialists in terms of advanced hematology or refractory seizure management, orthopedic surgery, and so on. And then really, I suppose, mostly according to diagnostic confirmation in national laboratories. We'll refer you to the diagnostic card we put together after the last meeting, where we can signpost to particular services that might be available for helping with diagnosis. There's an opportunity to collect data to understand natural history if we pool patients. And of course, you can always reach out through to the IGA or the IWGDD for help and support. We're available online. We can have calls with people, and we very much would welcome you to come to our online webinars like this one and to our meetings if you're able to attend. We should be realistic in our expectations. As we started off, neuronopathic Gaucher is a progressive condition. We can ameliorate some of the systemic problems, and that does seem to have some positive impact on the neurological progression. However, there is a decline regardless of that, regardless of the treatment, and life expectancy overall in our more severely affected patients is reduced. So quality of life is an important goal, with assistance of symptoms, trying to control and prevent seizures if possible, preventing infection, psychological support, preserving dignity and quality of life, and supporting our patients and our families. So this was a case of a young boy diagnosed with neuronopathic Gaucher disease, maybe a little bit late at the age of 8, but without access to enzyme replacement, and benefited from pain management with paracetamol, weak opioids, and gabapentin, with seizure control, and with hematology, and then supportive care aimed around maximizing skeletal strength and mobility, nutrition and education with regular monitoring. So it's a difficult circumstances to manage all of this, but this is achievable. Of course, we will also strongly advocate and try to help with enzyme replacement therapy for your patients. So in conclusion, neuronopathic Gaucher disease does represent a real challenge for all of us, but particularly in resource limited settings. We can't stop that neurological progression, but we can do much to provide comprehensive and compassionate care using what we have in those resource limitations. So I'm going to stop sharing and hand back to Vesna. Thank you.
Good. Thank you for that wonderful overview of the disease and the spectrum. And what I'm really delighted to hear was all the kind of practical things we can do. Now, please continue to put your questions in the chat. I'll get to the comment first, but I want to cut off with a question first. And the first one's going to go to Aimee. And this is just, we live in a strange world, but tell me, what is your advice on immunizations for children with GD type 3?
We want them to be immunized is the short answer. So yeah, please immunize the children. If you have whatever your local policy is for immunizations, I recommend that they receive them.
Good. And then I've got a question to the both of you. We see a lot of pulmonary infiltrates in our patients. Are they of any significance, and do we need to do something about them, or do we just ignore them? And I've just looked at the data. We see them as early as 3 months of age.
Yeah, and we see that as well in some of our patients, not in many of them. I guess the One answer is that there isn't a lot that we can do about them. ERT doesn't seem to have a massive impact on the pulmonary side of things. So you're thinking about symptomatic management. So if they're clinically symptomatic, then optimizing that symptomatic care, which can be a mixture of inhalers. Some people have used steroid medicines, but you kind of don't want kiddies to be on steroids forever and ever. So short courses, if there's an exacerbation, an infective exacerbation that you might see. But there's not a specific treatment that helps to resolve them. Now we have seen some, there are very few, but there are some reports of using substrate reduction therapy in combination with enzyme replacement therapy, but it's not an established approach to care. And obviously it's not easily accessible. Even if I wanted to do that for one of my patients, I would have a fight on my hands to try and get hold of substrate reduction therapy on top of ERT. But that would be, if you were in a situation, and we see that particularly in certain groups around the world. I know there's a cohort in Mexico where the GD3 patients, they die of their lung disease. They don't die of their neurological disease or their systemic Gaucher disease. It's of the lung disease, really sadly. So, and I know that there are groups researching to try and understand who and why are those particular patients more vulnerable to this lung infiltration. But yeah, there's not an easy answer, unfortunately, but systemic management and recognizing it so that you can try to minimize the infective exacerbations, kind of like a chronic lung disease patient.
Yes, and I agree with all of that. And in fact, we've had patients with pneumothoraces as a downline complication, which has been very tricky to manage. So I think being aware, monitoring and supportive care if you can. We've also used substrate reduction therapy, but recognise all the limitations around that.
Good. And then there's a comment in here which says, this is an interesting talk in largely USA-based GD3. It's not always progressive or life-limiting, at least for 40 to 50 years, with a wide range of cognitive abilities. We do have significant cohort of common L483P, or like most people know them, the old L44P, because people tend to know that term better. Who span the GD3 spectrum, including those severely affected by their disease, was life-limiting at least one grandparent. And it leads me to the next question. And before I talk specifically about sub-Saharan Africa, do you think the phenotype runs through in families, or is the modifier genes starting to become more significant?
That's a really good question. And I think it's debated is the answer there, Chris. I think we've got different people with different opinions. We have siblings with GD3, and their phenotype is often similar in my experience, but I know that there are reports of siblings with divergent phenotypes, and so differences in how they present and what their disease course looks like. And when we think about the genotype and its influence on the phenotype, I think there are some genotype-phenotype correlations, but as the comment kind of indicates, for that common genotype, which is a pan-ethnic genotype that we see around the world, there are a few different phenotypic groups. And so we also have patients who have the same genotype and they're in their 60s. They've got a very subtle eye movement defect, very little else that would tell you they have neuronopathic disease. And we have the same genotype in some infants with really profound, aggressive, rapidly progressive disease. And so we do suspect that there are some modifiers to that phenotype, and some of those modifiers are likely to be genetic, and we're trying to understand what they are, I think would be my summary to that.
Anything to add from your point, Derralynn?
Yeah, I agree. I think it is really interesting, the range of phenotypes. And within our UK population, so people who are Caucasian within that population, on the whole, we've seen with a milder phenotype, even with the same genotype. So I think that, there obviously are modifiers. There was a project ongoing some years ago to look at those. I've not seen a readout for it.
I think it's soon to be reported, I'm told. I'm awaiting a draft to review.
Good. No, because that leads to a typical now we may have just ascertainment bias in Africa because we see the classical phenotype with very severe disease. I have yet to see anybody beyond the age of 20 with this phenotype. Now it may be ascertainment bias that the ones which has got the milder phenotype, we just don't diagnose them, is the one reason. But the other reason why I think your comments are really important is that people shouldn't get completely despondent when they see this phenotype on the genetics and think, oh, this is the severe Gaucher. We shouldn't treat it because it's going to be bad always.
Absolutely. And I think that's really important, Chris, really important. And I think you're absolutely right. I think when we looked at our UK cohort, there were a group of patients who actually had lived their entire lives with a GD1 diagnosis. And it wasn't until really, really detailed clinical examination we were able to actually say, well, they have these features and these eye movements. And so really technically by the definition, we should move them into a GD3 group. But for their clinical functional life, they're really more like a GD1 patient. And I think that's also a really important point, because we've had patients, I remember a family telling me when their child reached 25, they did not want to come to clinic anymore because they were told that that was the oldest GD3 patient ever to have lived. And when I told them, no, I see patients in their 40s, I've got people that have had children with GD3, but the same genotype, there was a sense of relief that suddenly this didn't mean that this was their prognosis had suddenly changed for them. So I think having an awareness as, people treating, so as doctors, clinicians caring for these patients, we need to have that oversight that there is a spectrum, and that there isn't a single piece of information which tells you what your life is going to look like. And we have to piece everything together, and we treat the patient in front of us. We don't treat a test result in isolation.
Good. Wonderful. That's what I wanted to hear because it's exactly the message we give to our patients as well. I don't see. Okay, here's another question. Can swallowing difficulties develop much later in life, even when a patient has never had any problems in the past?
Yeah, they can. They can. So your ability to swallow is something which has lots of complex neurological networks that affect how you do that movement. You don't realize how coordinated a movement swallow is. So there's partly bulbar control, but there's also cerebellar control. So there's lots of different parts of your brain that are impacting that. And we know that often very, 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 very slowly over time, there are changes in the brain because of the Gaucher disease. And so you can have subtle difficulties in swallowing over time. They're not always profoundly dangerous immediately, but they are something to be aware of. And then so that modifications can be made. So you change the kind of food that you eat or the size of the food that you eat. You take more time when you eat. It doesn't always mean that you have to stop eating, but you want to monitor that and be aware of it, so you can make adjustments to keep things safe, and also sometimes if we're seeing a child perhaps with a swallow impairment, then we might initiate alternative routes of feeding, so that they make sure that they keep their nutrition, but we keep some food by mouth because food is wonderful and we all like to eat, and that is a pleasure, and we should be focusing on things that bring us joy and pleasure as well, not just things that we worry about as doctors. So it's getting a balance.
I'll add a comment there because it's around swallowing. Very interestingly, we see some of these swallowing difficulties as early as 3 to 6 months of age in some of the children. But a lesson for us is then a lot of it may be linked also to partial malnutrition. So sometimes you end up tube feeding them for a few months. Then they get their nutrition state back up and they regain their swallowing. So it's not always just pure bulbar. So again, my message is don't give up on children when they have swallowing difficulties. It may be a phase. Which just needs supportive therapy.
And especially in the really little ones, because you have to think, they're brain is trying to grow and develop, but it's also under attack of this condition with that malnutrition underneath it also. Actually, the brain has kind of been put under a lot of stress during that period of intended development. So I think you're right that we reassess, reevaluate once we've corrected one aspect, taken one stress away, can the brain then continue to progress and develop?
And then I've got one more. I don't see questions coming up just for you, Derralynn. Where are we missing the adult patients? Why don't we see, if you have to take a guess, where do you think, seeing we've got, it looks like mostly this phenotype or maybe this mutation seems to be very common in sub-Saharan Africa. So where would I hate the word mild and I hate attenuated, but let's say, where would we find the patients which are not as severely affected?
So I suspect we would find those patients in rheumatology clinics with bony manifestations, and probably relatively well preserved neurological function in the younger adults, possibly pulmonary, as we mentioned. But I think my experience of seeing pulmonary manifestations is those patients tend to be a little bit more severe, and so I think they would have presented in childhood. So I think in bone, maybe through hematology also with splenomegaly.
Yeah, good, thank you. And I will put the question out there, if there is anybody out there, and even it's afterwards listening to the webinar, who's got an adult patient, but actually over the age of 20, could you please agree to present that case to us, just that we all can learn, that we just want to know what is the trajectory of these patients, just that we can try to be better at finding the adult patients as well. Thank you, everybody.
Thanks.
Have a good evening.
You too. Bye-bye.
Bye.
Good evening, everyone.